Okay, good afternoon, everyone. My name is Michi Yukawa, one of the organizers for the Geriatric Ground Round. Sorry for the mess, but I'm in a shared space. But I am delighted to introduce and welcome back Dr. Helen Chen. She is currently a Chief Medical Officer of the Hebrew SeniorLife, a Harvard Medical School affiliate, which offers long-term care, post-acute care, and outpatient services. She's also an assistant professor at Harvard Medical School, and she's alumni of the California Healthcare Foundation Leadership Fellowship Program. Prior to joining the Harvard Hebrew SeniorLife, she was the Chief Medical Officer of the Center for Elders Independence PACE program in the East Bay, and the ACOS of the Geriatric Palliative and Extended Care at the San Francisco VA Medical Center. Dr. Chen serves as the Admissions and Readmission Committee of the National Quality Forum and the American Board of Internal Medicine Geriatric Examination Subcommittee. She is an expert administrator as well as a very skillful quality improvement work. What you may not know about Helen is that she enjoys knitting and she is an excellent chef, which I know because I used to live with her during my medical school. Anyway, please join me in welcoming back Dr. Helen Chen.
So thank you so much, Michi. And yes, Michi lived to tell. She ate more than one of my meals and she's still here, which is really great. Thank you for that lovely introduction. So the title, as you can see, is It Takes More Than a Village, a Mid-Pandemic Post-Acute Review. And Louise and I talked about this many months ago, and I had been hoping that we would be through the pandemic and it would have been a post-pandemic post-acute review, but alas, we're still in it. I have no, let's see if I can get there, yep. I have no relevant disclosures for this presentation. So the last time I was with you, I was actually with you in person. This would have been December of 2019. And, you know, Union Square was packed and, you know, people, COVID, what's COVID? And, you know, Wuhan was just another city in China that was having some kind of, you know, virus problem. We were not that concerned. We were full of hubris and we didn't think it would come here because, you know, our experience with SARS last time was actually quite benign for most of North America. Obviously, you know, Canada and a few other cities on the coast had issues, but, you know, we sort of like, well, okay, you know, we'll be fine. And I think we tried to convince ourselves that it wouldn't be different this time. Of course, it didn't take long to catch up with us. And by late February 2020, the infamous Biogen International meeting that occurred at Long Wharf Marriott in Boston created a local outbreak. And ironically, that was also concurrently where the Harvard Medical School Geriatric CME was being hosted. They overlapped by a day or two, and I got lots of panicked phone calls that weekend about, should I quarantine? Should I stay home? What should I do? I didn't meet any of the Biogen people, but maybe the staff were the same, and we were very, very worried because testing was largely unavailable. You could get it through the Department of Public Health, maybe if you had traveled to China and come back, or maybe if you knew someone at Quest who could get you a swab. But it was very hard to come by. And also that same weekend into the first week of March, we had an outbreak of respiratory illness on 2 of our long-term chronic hospital units, and we were incredibly worried. I remember camping out in the infection control office trying to figure out what to do, and basically getting advice from DPH saying, well, if they test positive for some other virus, it can't be COVID. Well, we know how that worked out. In any case, there was a significant RSV outbreak and everyone breathed this huge sigh of relief. Okay, great, it's not COVID. But, you know, point of fact, RSV is a bad thing. And, you know, the death rate from that particular outbreak was 25%. So in many ways, you know, we didn't know what we didn't know. And we felt like we had dodged a bullet, but really one of my attendings said to me, it really was like this. You know, we were frogs in that pot of warm water slowly getting boiled. And boy, did we get boiled. And, you know, for all the hubris and all the thinking that we were ready, we were not ready. So the objectives for this talk are really to review the impact of SARS-CoV-2 on post-acute care. And when I think of post-acute care, it's not just the people who are being discharged from the hospital. So it's really more like extra acute care, you know, all the things that happen outside of the hospital that impact seniors. So it really is more than just the people who go to skilled nursing. So wanted to describe some of the infrastructure and relationships that we built over the years involving government, academic, and community collaborations that were critical in supporting us before and during the pandemic and helped us to get through this third surge, which we did very well, but nonetheless, it was instrumental in helping us to get to where we are today. And to describe opportunities for quality improvement that occurred during the pandemic. So just a reminder, this is who we are. So this is the original building. This is where Hebrew SeniorLife started in 1903 as a small rest home for elderly Jewish widows. And currently, this is not even the full scope of what we do, but we have 625 long-term care beds that are uniquely licensed in Massachusetts as chronic care hospital specialty beds. It's interesting, although for all intents and purposes, it is nursing home level of care. We have 143 skilled nursing licensed beds, 2 adult day health centers, multiple outpatient rehab practices, 2 continuing care retirement communities, 3 supportive senior housing communities with mixed income levels, 3 primary care geriatrics practices, community-based, home and community-based care, hospice and home care, and also assisted living and dementia care across multiple sites. And this is really all built on a foundation of teaching, postgraduate training, and research, which is very, very special and also instrumental into how we've gotten through the last 20 months. So this is very simplistic, and you could argue with me about how I conceptualize this, but the pandemic showed us how truly interdependent we are. And you could argue that community isn't just one circle in the Venn, it's actually the overarching, umbrella of everything. But we did have significant community support. We had excellent partnerships with the state and the feds, and also many academic partnerships that really helped us get through the last 20 months. So post-acute was and continues to be hit really hard. So the AHCA, which is the American Healthcare Association, sent out a survey to its 14,000 member organizations in SNF, nursing home, and assisted living. And only 25% of their respondents said that they would be in existence next year, that they are very worried. A lot of people are very worried about the future of institutional, residential, long-term care. 84% reported they had lost significant revenue due to fewer admissions. In the Commonwealth of Massachusetts, there were many closures in 2020, and just in the past 6 months, 7 additional nursing home closures have been announced. And here at HSL, we took a hit too. I mean, we had, depending on the facility, 18 to 30% drop in post-acute admissions, closure of our LTAC beds. We used to have a ventilator unit, and in the timing is everything rubric, we gave away most of our ventilators on March 1st, 2020, and we gave away our last vent on April 1st. And through most of 2020, up until the fall, a lot of 2020, we were closed to admissions because of concerns regarding infection control. And who would want to be admitted to a long-term care facility? Who would want to be admitted to institutional care during 2020 because of this? This is really only a snapshot, doesn't even include the earlier part of the initial surge. But, the number of COVID deaths in institutional long-term care were unbelievable. And according to the Kaiser Family Foundation, it was 30%, but if you had actually done the cutoff here, before the end of 2020, 40% of the COVID deaths in 2020 were really related to people who were living in nursing homes. And the story here, I imagine you all know what the story is here, but the story here and the reason why the deaths tailed off was, thank God for vaccination, because the vaccination programs that rolled out in long-term care facilities really happened in December, January, and February of this year. And that's the short story for the drop in deaths in 2021. So of course, CMS was worried, and they, commissioned a report on coronavirus and safety and quality in nursing homes. And a lot of great people worked on this report, Terry Fulmer, Jessica Callender-Rich, Dave Grabowski, David Nace, and a lot of it's so obvious. So many things went wrong for nursing homes in post-acute care facilities. I mean, anyone on this call could tell me what went wrong. There's so many issues with workforce, with testing, with screening, with PPE. on March 1st, 2020, we did an inventory because we had been used to doing just-in-time ordering. You know, you needed a box of gowns, you ordered a box of gowns, they came tomorrow. Well, that ended at the beginning of the first surge. And on March 1st, 2020, we had 795 masks in stock. We have 2,900 employees, and about 1,000 of those people are patient-facing. So it was a very scary time for all of us. And we had almost no ability to get new PPE in a rapid way because the supply chain totally broke down. A lot of PPE that we use in the United States are manufactured where? China. And there was a problem. So I love some of the concluding remarks in this report, which are that there is an urgent need to train, support, protect, and respect direct care providers. Absolutely. And is that happening now? I don't see it, but I'm hopeful, and we need to move forward with that. So that's really, you know, this is really where we are with all of this. And I think that a lot of the nursing homes are really in trouble and remain in trouble for the next wave or the next pandemic, actually, or the next infection control issue. So, and of course, staffing was and is a concern across the, you know, the extra acute or post-acute sector. And I'm sure many of you saw this Paula Spann article in the New York Times that featured our very own Helen Gao talking about, you know, staffing issues in hospice. We have many acute care hospitals who complain that they can't get people into nursing homes or post-acute care. And I say to them, well, you know, you poached 25 of my nurses, our nurses, and they went to acute care and we don't have the staff. So if you want people to come into post-acute, you have to be cognizant that we also need staffing and we need good staffing. So that's, again, speaking to the interdependence of the entire healthcare sector. So looking back, collaborations and partnerships were crucial even before the pandemic. So we spent a lot of time and effort and years building outstanding relationships and partnerships with the government, including the feds and the state, the Department of Public Health, with various stakeholders in our communities within long-term care and across healthcare networks, and of course, certainly within the academic community as well. So collaborations with the state, and I put that in quotes because we're also talking about, you know, relationships with the feds and CMS. So post-acute nursing home, you know, skilled nursing is very heavily regulated. So you've got CMS, you know, Medicare and Medicaid, and of course in Massachusetts, just like in California, we call it something else. It's called Mass Health. The DPH here regulates SNFs and long-term care. The Executive Office of Elder Affairs regulates assisted living facilities and home care. The EOHHS, which is the Executive Office of Health and Human Services, regulates ADHCs. And even before the pandemic, we had really strong regulatory agency relationships. We had volunteered, participated, we have representation on the nursing home licensing boards. We have worked hard on statewide EOEA projects, including Age-Friendly Massachusetts, Age-Friendly Dementia Massachusetts, Alzheimer's Disease Services. We had strong infection control relationships across networks, and we have been viewed as outstanding in terms of our willingness to do transparent reporting. Well, what does that mean? So, you know, we have a reputation of actually probably reporting a bit too much. Some people in DPH were like, well, that's not really a serious reportable event, but thank you for telling us. So we, you know, don't hide anything. Something happens, we tell them, we describe the quality improvement procedures that we proved in to prevent events of that sort from happening again. You know, in as much as, you know, anyone on this call can sort of argue with me about the value of the CMS 5-star quality rating system, I'm proud to say that 2 of our skilled nursing facilities are 5-star. The third one is a 4-star, and actually that does matter out in the world. We've had other experiences with previous infectious outbreaks. For example, a huge norovirus outbreak in 2018. We worked very closely with the Massachusetts Department of Public Health. They learned to trust us and our infection control people about how serious we take any kind of infection control issue. Obviously, we've had other RSV outbreaks, including the one that we had in March, which tragically did have some deaths associated with it. We have a direct line to Mass DPH clinical staff, which was critically important, especially in the early days of the surge, and also an exceptional relationship with clinical staff at the various boards of health. So here, unlike San Francisco, where it's the city and the county, here it's the state plus the various cities. So there's a Boston Board of Health, a Canton Board of Health, a Dedham Board of Health. And at times when we've had other, one-off issues like Legionella, we've worked very hard with the various individual city boards of health to make sure that any kind of mitigation actually occurred. So strong governmental partnerships lead to access to consultation and also for them bidirectional assistance. So we've helped the DPH with a lot of things over the years. And frankly, early on, we didn't know what we didn't know. And it was important to have that line to DPH. And frankly, they didn't know what they didn't know either. I mean, there were so many things, so much advice that, sort of evolved over time. The CDC was constantly giving us new advice, that it was so important to have that close relationship and that trust with the government. I know a lot of people politically are like, we can't trust the government, we can't, we are not going to participate in this. And I think that's a huge mistake. If you build these relationships and you spend the time building that trust, it is only to the good for your patients. The organization, okay, but your patients, and that's really what we're here for. We were able to get state-sponsored testing at a time when testing was so hard to come by. In assisted living, they had this program where they would send the National Guard out to test your assisted living if you wanted that, and that was incredibly helpful. And then because of the trust built over the years, HSL was asked to lead a statewide initiative to do virtual infection control consultations for other nursing homes and skilled nursing facilities. And that was built because of our relationships with the DPH and others within the state. And I'll talk about that a little bit later on. And unlike other regions, we had a very good relationship with our local CMS region officers, and we had the willingness to partner with the Federal Pharmacy Partnership for COVID vaccination. And they came and vaccinated our skilled nursing and assisted living units, our senior housing units, and all in probably close to 4,000 doses or more, maybe 5,000 doses were administered. We took care of the 625-bed long-term care patients ourselves, as well as the direct care staff here. And we also vaccinated one of the supportive senior housing units because we got into a discussion with the FPPP as to whether that's actually a nursing home level. And we would argue that those are frail older adults who are effectively nursing home level, but they put them at the bottom of the list. So we did that vaccination, and the Board of Health in that particular town was so impressed, they asked us for the technical support to stand up a senior vaccine clinic for the community. So in terms of community, this is actually obviously taken pre-COVID at one of our supportive senior housing communities in Randolph. Really, we have to think about it pretty broadly. So community includes the local long-term care networks. And there is something here, which I actually am not aware with California does this as well, but we have the Massachusetts Long-Term Care Mutual Aid Plan, or MASS-MAP. And it really is a coalition of Massachusetts Senior Care, which is an industry organization, Leading Age of Massachusetts, and also a little bit Massachusetts Department of Public Health. And it was really in response to their observation of things that happened in the early noughts of nursing homes who just melted down, literally melted down because of heat emergencies or hurricanes, and people died and nobody got evacuated. So this was a way to look at disaster and emergency response in long-term care, provide mutual aid to each other, build an emergency communication system, and be able to take care of our vulnerable elders. So I hadn't been here very long when there was an issue in the Spaulding Network. You remember Spaulding, the network that took care of all of the bombing victims, but they have many facilities across, Metro West in Massachusetts. And one of their centers had a water main break. So all of the HVAC and their water went down, as well as some electrical systems. They had no electricity, they had no heat, they had no water. So MASS-MAP was activated. And so we all got notified that there was an emergency and that patients would need to be evacuated. And 56 patients were transferred within a few hours, within 2 or 3 hours. It was actually quite impressive. We took 15, and the rest of the patients were distributed other facilities across the region. And this is all to say the concept of mutual aid is firmly established within the long-term care community. And what did that mean during the pandemic? Well, as part of MASS-MAP, we participate in regular tabletop emergency drills, which really set us up for, starting up our incident command for COVID, all of the staff were really familiar with the HIC system and how to do incident command drills. And so when we started doing it for COVID, people were really already on board. There was already an emergency communication network across the region that let us know how people were doing in other facilities. And people, because of the mutual aid issue, were willing to share things like, where are you getting PPE? Where, do you have a source somewhere? Are you willing to share? And, when it got really desperate, we all donated a box, a case. People, had nothing. They had no masks, no gloves, no gowns. Everyone pitched in and tried to help their, brother and sister organizations across the network, which was incredibly tremendous. So community includes our health systems partners. So we were, even before the pandemic, part of multiple skilled nursing facility collaboratives, which was a focus really on quality and cost-effective care. All of the collaboratives had standardized data collection and reporting with a focus on accountability regarding outcomes. I sent, my 27, total hip replacement people to you. How did they do? How long did they stay? Were they readmitted? So really a focus on readmissions, length of stay, and particular clinical outcomes. And we were in collaboratives with Atreus Health, Mass General, Brigham Partners, which used to be just Partners, New England Baptist, and also Beth Israel Lahey Health. And how do we benefit from this? Of course, the data collection and the standardization and the accountability was really important for improving our game, improving the quality across our networks. But one of the real benefits was this. We got access to rapid PCR testing. At the beginning, it was horrible. One case became 2 cases, then it was 6 cases. Every week we were probably in the early days of the first surge, tripling the number of cases because we didn't have anywhere, we couldn't test people. You could send it to Quest, you could get it back in 3 days or 7 days if you were lucky, 3 days if you were lucky. But Beth Israel Lahey Health became our main testing partner. They provided swabs at a time when swabs were hard to get, also produced in China and then to a certain extent Italy. And as you could recall in the early surge, Italy had trouble too. So the PCR turnaround time was 12 to 24 hours. And because of this, we were able to test close to 300 people a day at the peak. And we were able to immediately isolate cohort and remove people from general population who were infectious and protected other people. And this was so critical in stopping the spread in our buildings. We're deeply grateful, and we could not have gotten through this without them. Later on in the pandemic, we also had access to some mutual aid supports. They provided us with some doses of monoclonal antibody and also with PPE at times when we just didn't have anything left. And so we published a little brief report about this, and describing our experience pre-universal testing and post-universal testing. And at a time pre-universal testing, when case rates were tripling, in the weeks after we instituted universal testing, the case increase in case rates dropped to 10 to 14%. So hugely successful, helped us to actually stem the tide and put a lockdown on the outbreak. So community also includes our professional organizations. It's funny, when I was in San Francisco, even though I was in a leadership position, we were not joiners. We didn't really join a lot of professional organizations. And I've come to believe that they are intensely helpful. So Mass Senior Care is an industry organization focused on long-term and post-acute care. And what they offered us was a relationship with Department of Public Health leadership. There were regular monthly meetings to talk about how things were going, what we needed, what they could do to help. We are also very active in the Massachusetts Health and Hospital Association. Many of our staff, our board trustees there, have volunteered a lot of time to work on various councils and committees, including the Physician Leadership Council, the Physician Hospital Integration Council, and the Clinical Issues Advisory Council. So building that relationship took many years and was a lot of effort, and obviously was volunteer, but also critically important. Why? So MHA during the pandemic, we had a testing work group where there was representation from infectious disease groups across the Commonwealth, infection control groups across the Commonwealth, and the sharing of best practices and access, and discussion with DPH about what we were doing in terms of mandatory or universal testing, very helpful. There was a vaccine work group, which still exists, although now the meetings have dropped down to monthly. It was a weekly meeting, and again, representation broadly across the Commonwealth. And the best part of all is that people from immunization branch at the DPH attended every single meeting. So there was real-time problem solving about, I'm not getting vaccine, I'm having a delivery problem, I'm having a storage problem. And then there was actually mutual aid. So people who said, you know, I'm short one box of Pfizer because I gave out a lot of first doses to people because we got extra doses out of vials. Can anyone help me? And a lot of people on this call stepped up and actually redistributed vaccine to healthcare systems that were in need of more or in need of more support. The CMO work group on MHA has representation from MD experts in infectious diseases and also pandemic management that was hugely helpful. And one of the things that they helped all of us do was actually get more access to PPE, which was a critically serious problem during a lot of early 2020 into the summer. So moving on to the academic relationships. So these existed, of course, long before the pandemic. And it's unusual for post-acute and long-term care organizations. And I know that I was so excited to see, I think it was from Daniel Ruth, I got an announcement that JHCF is partnering with UCSF now, which is great. And Michi is spearheading that. And I think it's really wonderful. I think it really improves quality in post-acute long-term care organizations to have that strong academic partnership. There was a strong affiliation between HSL and the academic medical centers and Harvard Medical School, long before the pandemic. We also had really great relationships with nursing schools and with BU dental medicine, and collaboration with the Marcus Institute for Aging Research, which is based here at HSL. So it's a major teaching site for geriatric and palliative medicine fellowships, the BU Geriatric Dental Fellows, and Geriatric Psychiatry Fellows across the region. All of the Harvard Medical students come to HSL to have a geriatrics didactics day. I'm embarrassed to say it's a day, although the amount of curricular content in the medical school has improved over the last few years in terms of geriatric medicine. And the Beth Israel Lahey Health Department of Medicine is actually our home academic department. So, how did this play out during the pandemic? And, I could go on and on about that, but I just wanted to highlight a few things. So early on in the pandemic, there were people, went home, they're working remotely, and we needed help. We needed help with advanced care planning for many of our residents who were frail. We were worried, what will we do if there's a major outbreak here? Will we send them to the hospital? And we had people come out of retirement. We had faculty who were otherwise working remotely, palliative care faculty who were actually participating in this Telehealth Project to touch every resident who was in the facility but did not have a do not hospitalize order. And they were able to reach out to the majority of the residents, and a significant proportion of them, 39% actually decided for DNH during this time. And that was really helpful because at that time, there really wasn't that much to offer people if they went to acute care other than, ICU care or intubation. And most of the people that we were talking about were DNR, do not attempt resuscitation, do not intubate. So I think it was actually helpful for our acute care partners to try to limit the number of people coming into hospitals who didn't really want ICU care, and to assure them that we would provide the palliative care services here. So that was hugely beneficial. This is a poster from CAPC, who featured this project on their website for a few months as highlighting what palliative care can do in long-term care. Also during this time, from a quality improvement perspective, our acute care transfer rate dropped into the very low single digits, like less than 9%, actually less than 5% on many units. And so I think it's actually a direct result because of this work that was done through this academic partnership with palliative care. We have faculty who are involved in programs like NIA, NIA Impact. And Sarah Berry was really interested in the question of vaccine hesitancy among skilled nursing long-term care employee staff. And Sarah is a senior scientist at HSL Marcus Institute. She's also an attending physician on one of our long-term care units and used to be our geriatric medicine fellowship director. And she actually did a project where she used multilingual HSL staff to film videos encouraging people to take the vaccine, and created other resources written in other languages to target our staff, but also did this town hall project to try to reach frontline skilled nursing staff to find out why they were reluctant to take the vaccine. And so it was 196 participants in 50 facilities. The themes were identified. Many of them I'm sure you're familiar with. I'm afraid of, pregnancy and fertility issues. I'm afraid that there's some kind of microchip. It got developed too fast. I don't trust the government. And in addition to identifying these themes, she created some resources to help address these questions and themes to try to convince more people to be vaccinated. And we used a lot of her resources here at HSL in order to actually improve our vaccination rates. We have a mandate. You have to be vaccinated in order to work here. And we actually had that mandate before the state mandated it in post-acute long-term care. So, and when we first rolled the mandate out, we had 400 employees who were not vaccinated and told us they were not going to get vaccinated. And through the hard work and partnership with many people, including Sarah and her team and HR and other educational resources we have here, using some of her videos, her materials, and the translation, when we finally drew the line on October 1st, I'm proud to say, I'm sad actually, because some of these people are people that I worked with for a long time, but I'm also proud to say that out of that 400, we ended up with 20 people who actually ended up losing their jobs and moving on. So the vast majority of employees here, especially the patient-facing employees, actually are fully vaccinated from COVID. So another thing that we've been involved in for many years is Project ECHO, not born here, obviously, born in the University of New Mexico, but the flavor of Project ECHO here was really about care transitions. So set up a infrastructure, a video conferencing infrastructure, even pre-COVID, to reach skilled nursing facilities about patients who are being transferred from acute care into their facilities, with the idea that we could improve care and prevent poor outcomes and rehospitalization. So people were used to it. There was this sort of, BI and post-acute nursing home relationship where they already were used to having regular video teleconferences. So in the late spring, early summer of 2020, Governor Baker and Secretary Mary Lou Sutters of Health and Human Services realized that we were in trouble. Not we, HSL personally, but nursing homes and post-acute care facilities were in trouble in terms of the volume and incidence and death rates of older adults who had been exposed to COVID. And they decided that the key was to provide education and training and put some teeth behind this. That if you wanted a piece of the state funding to help you through this hurdle, about 130 million, you had to participate in the virtual infection control training with the awareness that many of these facilities don't have the staffing or expertise. In a lot of smaller nursing homes, the director of nurses is HR. She's the clinical educator. She's the infection control person. She's the quality improvement person, or he, but in many cases it is a woman. And they just don't have the time, energy, or expertise to really manage these things. So the state was willing to put some muscle behind this and actually have a program to provide this sort of technical assistance support and training to facilities who may not have been able to do this on their own. And they asked HSL to lead this and actually help design and disseminate the program. So this was a collaboration between Massachusetts Senior Care, the academic medical centers, and also HSL and the Marcus Institute. And Lou Lipsitz wrote a paper about this. It came out in the early fall of 2020, about what happened. So 360 facilities were offered webinars and consultation. And of these 360, 123 of them were facilities that were in trouble, had high rates of COVID, high death rates, a lot of infection control issues. In addition to the actual didactics and training, there were community resources identified for how do you get more staff, how do you get more PPE, how do you get access to testing, and the results are here. So the training started at the middle of May, And even for the special focus facilities that had so much trouble, their rates of infection and hospitalization also dropped to match those of other facilities. And so people always ask me, well, wasn't that the time when, COVID rates and community spread was dropping anyway? It was better, but there was still a huge amount of COVID in the community. And it really didn't substantially get better in 2020 in Massachusetts until probably mid-July. I mean, it was coming down, but it was really not substantially better. So, and then of course the ARC came in and created the ECHO National Nursing Home COVID-19 Action Network. And I know many people in San Francisco also participated in this. And again, in our region, it was a collaboration between Mass Senior Care, HSL, MGH partners, and also the VA. There were 9 cohorts, 16 weeks of virtual conferences, about 83% participation, and it coincided with the Thanksgiving surge, unfortunately, the post-Thanksgiving surge. And what we learned from this project is, from a paper that came out just this month, that what the facilities reported on after they participated in this program, they were very well received, that it improved collaboration, improved peer support, it improved the promotion of learning communities, and fundamentally the resilience and well-being of the staffs in those nursing homes, which, given all the things that are going on now, that is just tremendous. So moving on to quality improvement. So this is Joe Calabrese. He would probably be embarrassed that I did this. He's the Associate Dean of Students at the BU School of Dental Medicine. He's also the director of our dental services and our 2 dental practices. And he got a little tired towards the end of 2020. People would say things like, well, I didn't get to that. It didn't go well. I let it go because of COVID. It's COVID. And he started to say, people, it's a pandemic, not an excuse. And we're still responsible for the quality care of the people in our facilities, in our communities, and in our practices. So quality improvement in the time of COVID. There's a lot that I've already talked about that could fall in the rubric of quality improvement. Obviously ECHO, COVID-19, the virtual IC consultation, vaccine hesitancy education, the advanced care planning telehealth project. And we continue to do what has been foundational for our organization for the last decade, which is really quality improvement education and lean training, which actually, ironically, got easier during COVID because a lot of people already were invested in doing virtual education and training, and a fair number of people were working remotely anyway. But it's a good time to remind everyone that the things that we care about in long-term care, including quality improvement, including quality indicators, kept on happening during COVID, and we needed to keep on paying attention to them, in particular antipsychotic use. And then there were some things that we did that were operational, as I call them, operational quality improvement issues that were simply born of necessity regarding PPE and about staff empowerment. So I think I told you about this the last time I was with you. We were worried about our antipsychotic use rate because looking back, we were much higher than both state and national average. Currently, the national average is about 18% in long-term care facilities, and in the state, it's about 14%. And we worked very hard on this. There were multiple iterations of different quality improvement projects over the years. And last year, we got down to a combined rate of 14.4%, probably because the changes that had to be put into a lot of facilities related to COVID impacted the usage rate. And frankly, some people who were on antipsychotics during that time died because of COVID. But in the months subsequent to the first surge, we had a significant uptick, which really worried us. From 14.4% to 15.8% this fiscal year doesn't seem like that much, but when you boil down on it, it's pretty significant. Overall, almost a 10% increase, and at one site, 15.2% increase. So putting our lean hats on and our quality improvement hats on, there was a root cause analysis, and there were a lot of issues that happened. Again, it's a pandemic, not an excuse, but there were process breakdowns. There were changes in the patient population. We admitted 110 people between July and December of 2020. And a lot of those people came in on antipsychotics, had been desperately hanging on in assisted living or in hospitals or in home settings, and were being medicated in order to enable them to stay home. So there were some processes related to admissions, and we moved away from taking a holistic, patient-centered, non-pharmacologic approach and to more of a task-oriented approach, which really, if you think about it, the number of times and the amount of effort it took to don and doff PPE, staff were incredibly stressed during this time. But we also decided that part of the problem was creating a better algorithm and a checklist for prescribers so that we could actually get the gradual dose reduction program going to get more people off of antipsychotic medications if they did not need them. So that is ongoing. We're hopeful that that will continue to improve over the next couple of quarters because we really would like to get the rate down below the state average, which is still 14%. There were also some operational quality improvement and process improvement issues that were born out of necessity. This is sort of a silly example, but I'm sure you all recognize this. These are those yellow isolation gowns that we used to all know and despise, for people who had MDROs. And they were cheap, they were flimsy, probably cost less than $1 back in the days before COVID. Well, the price shot up. These are all made in China. And, even if you were willing to pay $20 a piece, you couldn't get them. And, the price really has not stabilized substantially. It's improved, but it's still very expensive. So we tried various, quality improvement issues, iterations, different kinds of gowns, paper gowns, cloth gowns, different kinds of vinyl, sort of plastic gowns. We were using aprons from culinary. We found 2 cases of chemo gowns when we used to give chemo in this building, and we were using those. They were hot and they were hard to wear, and actually people were reusing them, which was a no-no from an infection control issue perspective. And finally, someone said, why are we even doing this? Why are we doing this non-ecological thing with disposable gowns? So we got a team together, we spec'd what the gowns should look like for us, and we actually found a North American vendor who had lost business related to COVID and was willing to make us reusable gowns. And so that's where we are at now. We use reusable isolation gowns. We have a process improvement that took a few iterations for how these gowns are laundered, and that has really helped in terms of staff engagement, feeling protected, feeling that we made an effort to actually protect them during the pandemic, even if we had no access to the equipment that we used to have. Another operational quality improvement and process improvement issue was born out of necessity, was related to staff empowerment. So, clinical leaders were busy firefighting. Historically, frontline staff problem solved by escalating up, oh, I'll just tell the CNO, or oh, I'll just tell the CMO, or oh, I'll just tell the medical director. And we had started operationalizing tiered huddles, which is I can tell you more about this at another time if you want, but basically what it does is it returns the problem-solving ability to frontline staff and teams. The discussions are facilitated by process improvement teams, and basically using things that they learned during lean training or quality improvement training. For example, one of the things that came up during one of the tiered huddles was a nurse said, we really need scissors. And so the question was, why do you need scissors? Because I can't open the Tylenol packets. Why can't you open the Tylenol packets? Well, the old packets used to be terrible, but now they need to be cut. Well, why did we move to new packets? Well, because we got a new vendor. Why did we move to a new vendor? I don't know. And, it stopped there. And then it went back down to, do we need to use this vendor? Can we go back to the old packaging? Is there a reason why we needed to actually change this that added, many minutes to a nurse's day if every person is on scheduled Tylenol and she's busy hunting for scissors? So we solved that problem. We returned to the old packaging. It did not need to be escalated up. It was handled by the nurse manager on that unit, and the problem of we don't have enough scissors actually went away. So it's a very basic example, but this sort of thing builds team self-efficacy and also trust that the leadership actually trusts them to use their judgment to solve clinical problems on the front line and take care of things at an appropriate level rather than always trying to escalate things up. So we're we've done this for many months now. We're actually expanding this across the units, and we're hoping to do an assessment in terms of effectiveness in the coming months. But, I will put here that workforce resilience and retention is really a critical QI issue right now. And, let's face it, the moral injuries of the past 20 months exceed the power of yoga and nice lunches to heal. That's just the truth. And so one of our teams really wanted to do stress first aid, which I put the links here, a program that is really about building resilience and peer support and recognizing when one of your colleagues is having a stress injury, originally developed by the military, actually. And there's a lot of information about it at the VA if you are so inclined to read their information. It's all available for free. The Schwartz Center does it if you're part of the Schwartz Center program. But really, really important and has been very effective here among frontline staff. And if you can't do that, maybe you want to build your own. So this is Dr. Olivia Liff, one of our geriatrics attendings, who told us just before the pandemic that her passion is wanting to do balance groups with medical professionals. So we have enabled her to actually become balance certified. I think her examination is coming up in a couple of weeks. We're very proud of her. But she is actually running balance groups in the training program, and we would actually like to expand that across the organization if we're able to get that done. So, COVID highlighted the vulnerabilities of post-acute care or extra acute care. Absolutely the absence of systems training and expertise, inadequate funding, inadequate supplies, PPE and staffing, some scary moments there when we really had not a single clean mask in the building. And we were, hunting around for another organization who would either sell us some, loan us some, or just gift us some. And we have highly vulnerable populations in built environments that are not designed for isolation or infection control. So, when we think about what the pandemic has revealed to us, long-term care has to change. And part of that change has to deal with, the importance of collaboration. We have much, much, much to improve and a long way to go, but I'm enormously grateful for the partnerships and collaborations we had with various organizations in the community and also with our state and also with our academic partners. So I'm going to leave you with this. I have many pithy, I'm known for my pithy leadership statements, and one of my statements from my ER days is this: if you are floating on the sea of uncertainty, or in this case, the river of uncertainty, make sure you have plenty of company in your boat. And I hope that the next time that I meet with you, COVID will be far in our rear view mirror. And I'm just hoping, but I can't guarantee that. And we'll have to see what happens this winter, keeping my fingers crossed that we won't have a twindemic. But, we're moving forward with mandatory vaccination for all, and I think that will all be to the good. So thank you for your attention. I want to thank my colleagues who helped me with a lot of the content on this slide, and I'm certainly willing to take any questions that you may have. Thank you.
Thank you so much, Helen. That was tremendous. And I'm going to read a couple questions from the chat, and I think this just highlights such the power of collaboration. And so the first question really is about, do you see your new partnerships moving into new topic areas and new endeavors as the focus of COVID becomes more routine?
Oh, I hope so. I mean, I think, it would be a shame to not really continue to build on what we've taken so much time to foster and grow and develop during this time. I do think that, we can't just sit back and expect that, COVID will be, gone and there won't be another challenge. I think the next challenge will be workforce related issues. Is there a way we can share with each other? One thing we did do, which was incredibly helpful, was, we had trouble hiring aides. So what did we do? We created our own aide training. We have our own CNA training program. So that is something we built here. And we have trained quite a number of aides, some of whom stayed on and some of whom went elsewhere. That's okay. You can't nail people to their seats, but if you can't find the workforce that you need, maybe you have to grow them yourself, and maybe we can collaborate with others to actually do that, and also work with our health systems partners to realize that if you offer all of the skilled nursing facility nurses $25K to come work for you tomorrow, then you're not going to move any of your people out of acute care into our facility. So we need to partner and collaborate and be supportive of one another, and we have continued that conversation with BI Lahey Health. We have a really good relationship with their chief nursing officer and their case management people. So around those issues.
That's tremendous. I'm just thinking about how important it is to build partnerships and how much time that takes, and sort of how was this multiple people? Is like, how do you, and do you protect people's time, or like, I'm just trying to figure out how do you have the time, which is very important time to build these partnerships. I guess what would that look like, or how did that?
I don't know that we actually protected many people's time. Some people did get a bit of protected time for this. Certainly our, attending who's doing the Ballant group, she gets protected time to do that training and to lead those groups. But in terms of our volunteer work for various organizations and various acute care health networks, a lot of that is voluntary. And it came about because I think 5 years ago, my boss, Mary Moscato, the president of our organization, said at a leadership meeting, all of you need to have something you do outside. I expect all of you to do something with BI or, mass, senior care or, MHA. You all need to volunteer for something else. And if you don't have the bandwidth, come talk to me. We can see what we can take off your plate for this. I think most of us ended up just doing it because a lot of these meetings happen, off hours. I have many meetings tomorrow evening actually around this issue, but it really, and some people are a little grumpy about it, I must say, but honestly, it's been so important. And just having had that opportunity to work with people during a time when it wasn't a crisis, where we actually got some things accomplished, when I called them up and I said, hey, really, I need you to help me with this, it was incredibly valuable and incredibly important. And they saw that we were willing to pitch in and participate and volunteer. So those things were incredibly important.
Terrific. The next question in the chat is, clearly the right leadership enables groups and organizations to do well in incredibly hard circumstances. What you did at Hebrew Senior Life is incredible. The entire field of geriatrics is in trouble. And what are your ideas for what we can do to change that? Would love to hear your ideas for collaboration and creativity applied to that issue, either nationally or locally at UCSF or Harvard.
I could give you the cynical answer, which is follow the money. I mean, the fact is a lot of our primary care colleagues are dropping Medicare. It's on the one hand, it's a reliable payer. On the other hand, it's not a great payer compared to Blue Cross. And, if we value something, we should be willing to pay for it, right? I mean, if it's really important, it's sort of like you value these aides. Okay, so why are you paying them $13 an hour when they can go work at Costco for 18 bucks an hour and not have to wipe people's bottoms? I mean, let's be real here. So all of our aides have gotten a big raise. We're moving them to past minimum wage, Massachusetts minimum wage, not federal minimum wage. And because we want to keep them, they're very important to us. That's, if you really value the work, you got to value the people in a way that they understand. So I think that's important. I don't think geriatrics is going to get a lot of respect until we can actually change the financing and the reimbursement. But I also want to say this to the geriatricians out there in the world, of which I know we're shrinking in number. I know we're in trouble. I know people don't want to do it. I know people, I work for the ABIM. I know people aren't resurging. I get it. But when you talk to people at Blue Cross, they want you because you actually understand complexity, you understand ambiguity, you understand older adults, you understand the clinical care of older adults. There's quite a number of people filling senior leadership seats in health plans who are actually geriatricians, who are in decisional seats across the Commonwealth, who are geriatricians. The head of Mass Health is a geriatrician. The CMO of Mass Health is a geriatrician. The former CMO of Mass Health was a geriatrician. There are a lot of organizations, governments, Medicaid ACOs, Medicare ACOs, sort of things a little bit outside of academic medicine. They're looking for your expertise. You are valued. Maybe you don't feel that valued some days, but I have to tell you that there's a lot of people out there who want geriatricians to come and help them with systems redesign, with helping them with complexity. And I think it's actually pretty amazing. I will be honest, they don't want you to come and bring a lot of Medicare patients because it's really hard to make a margin or a bottom line on a high prevalence of Medicare patients because the reimbursement is not great. But, in terms of your knowledge base and your expertise, you're in demand. I will say that to the fellows. I will say that to people who are in geriatrics, and in particular, people in geriatrics who are looking to sort of step maybe aside from clinical care.
How do you learn about these opportunities to work with health plans?
Okay. I mean, part of it's the relationship, right? So like, we're part of the ACO, so you hear things through other people who you encounter through the Mass Health, sort of Mass Health. If you're part of these meetings, if you volunteer with the local, organizations like Mass Senior Care or Leading Age, or sort of organizations that I really didn't have much time for when I was a full-time academic, I'll be honest, but they are your gateway into other opportunities. Talking to people at Blue Cross. In fact, I met a geriatrician at Blue Cross because I gave a talk somewhere, and he introduced me to other people. Now, I don't want to work for Blue Cross, but certainly he has really, opened my eyes towards, the number of geriatricians who actually are working in health plans. Certainly PACE is a way of getting health plan experience on a very small but very mighty level, because you learn a lot about health plan management through PACE. So that's another way of getting that experience, and also being, getting into a relationship with people in CMS who may have actual contacts with people who would be interested in hearing from geriatricians for this kind of work.
Terrific. And that you could have an academic partnership as well, right? I mean, in terms of.
Absolutely. Yeah. Absolutely. Absolutely. Yeah.
I had a question. I thought it was really, thinking about faculty, staff burnout as a quality improvement issue. Like, I thought that was a really great way to say. And actually, I'd love to learn more about the first aid initiatives that you're doing, or anything else that you have found helpful. Because I know, long-term care, actually, a lot of the healthcare settings are just so understaffed, and that leads to more stuff falling onto the people that are there.
Right. So Stress First Aid, we didn't design it. It's actually, a widely known program. There's resources on the AMA website, Schwartz Center website, the VA PTSD website, of things that are free. You can just, pick them up, download them, use their manuals, use their training materials. And what we have done is rolled this out for frontline staff. And we have, they're not thermometers, they're sort of dashboards across the various units of, please check in with your colleagues about, are you in the red zone? This is sort of the language of Stress First Aid. Really, how are your colleagues doing? And are you noticing things that indicate that they're having a stress injury, and that maybe they need to take a moment, or they need to, speak to someone, counselor. There's a lot of free counseling that became available during COVID. And we actually partnered with an organization that provides that free counseling. I don't know how much uptake we've had of that piece actually, but at least it's available to people. And I do think, certainly we have plenty of burnout here. We have plenty of people come to my office and say, I just need to get out. If we have another surge, I'm out. I hear that a lot, and I don't blame them, because I think that too. If we have another major surge where there's, a lot of, there are many cases and a lot of poor outcomes, then, I don't know. Every surge, I think, okay, this is my last surge, I'm out. But then, every surge we learn something. And I have to say, this last surge, which I call the 4th of July surge, people got all excited and went out for 4th of July because we had no cases in Massachusetts, and everybody went to Provincetown, had a wonderful time. And then all of a sudden we started getting cases, breakthrough cases. The truth of that is most people weren't very sick, and most people did fine. And we had plenty of Regeneron. We gave people Regeneron, and people did great. And we learned a lot about how to take care of people who were COVID infected. And I do think that vaccination made a huge difference. So in terms of first, Stress First Aid and dealing with burnout and helping people recover, I think it's going to be a long time. I think this is going to be with us a long time. And I think we have a generation of trainees who are going to be carrying this with them a long time, which is really hard. I do think that Massachusetts now has paid family medical leave. I encourage people to take PFMLA if they need to. We try to work it out. You can take intermittent PFMLA. You don't have to take a month off at a time. Let's say you need to drive your kids to school, your kids in special ed, and, being on a COVID unit makes you nervous, or not that we have a COVID unit anymore, but, working in healthcare makes you nervous. Can you take a couple weeks? Sure. We can do that, and, and you will get paid. And so that is really a huge undertaking for the state. I'm so grateful. And we try to work with people around remote, remote work, we try, obviously clinicians, it's really hard. If you're a nursing home doctor, it's really hard to do remote work, but, trying to protect people, trying to ensure people have the tools that they need to feel safe.
Mhm.
It was a little scary back in early, spring, summer 2020, when honestly, I felt every day, every staff case, and we had staff cases, it was like a knife in my heart, because I had sent people to the front lines and told them to reuse their N95 mask. It was awful.
Mhm.
And so, just being at a point now where we have spent easily $2 million on PPE, and actually our director of central supply said to me, I don't know, Helen, if we don't use these masks, where are we going to keep them? It's sort of like I've got them in this, above the ceiling and cabinets and closets. I'm like, Tony, we're just lucky to have them and just be grateful. And
Yeah.
so that's where we are with that. So we spent a lot of time and effort and money to make sure people had what they needed in order to be safe. We bought 20 Pappers. We had Pappers in around H1N1, and we never used them. We just thought, okay, pandemic is here. We're gonna buy these Pappers. And when we took them out for COVID, they were all the batteries had died. A lot of the gaskets had become, defunct. And because they were so old, there was not a single company that would provide us with a battery. So that was a lesson for us in terms of, if you're going to buy this kind of equipment, then someone needs to maintain and take care of it and make sure it's usable by staff. And at the end of the day, we had a couple of Pappers and people didn't like them. So we actually just, pushed forward on the N95, gown, eye protection kind of, movement, instead of trying to buy a lot of Pappers for people.
Well, thank you so much, Helen. What you've done at Harvard SeniorLife and your colleagues is just impressive and inspiring. So I appreciate you sharing this with us, and it's been really a lovely presentation. So thank you.
Well, thank you for inviting me. It's always great to see all of you, even virtually. So anyway, so thank you.
You're getting lots in the chat saying thank you, thank you. So thank you, Helen.
Mhm.
All right, take care. Have a good night.
Bye-bye. Good night.